I am Dr. Vivek Kaneer, and along with two of my colleagues, Dr. Painse and Dr. Nanda, we are a group practice based out of a small town in Madhya Pradesh in the center called Bhopal. I've been doing this business now for 30 odd years along with my colleagues, so we have a fairly vast experience. We work in multiple hospitals, but Chirayu is our main focus, and we also work in two other places, which I would perhaps emphasize considering the fact that I'm going to be sharing my views on minimally invasive cardiac surgery. The two other hospitals are Mandan and Anand. As of now, minimally invasive cardiac surgery in our group is primarily focused on Chirayu Hospital and Chirayu Medical College. We are trying to get these two other hospitals to also actively get involved in a minimally invasive cardiac surgery program. My whole idea for minimally invasive cardiac surgery stems from a very simple fact. Try getting an 18-year-old or a 20-year-old girl who has rheumatic mitral valve disease sitting in a village or maybe in a tehsil or a taluka. Try getting her married with a scar which extends from here to here. The same girl with a small scar extending submammary or maybe transaxillary, voila! It doesn't show. So cosmesis is not the only concern. It can be done very safely. And as a unit, we do ASDs, aortics and mitrals very, very safely through a right thoracotomy or a transaxillary incision. Certain issues which come up with the West very rarely come up with Indian population. You see, in the West, they are talking of doing minimally invasive in degenerative valve disease, calcific aortic disease of the elderly, in whom peripheral atherosclerosis and therefore access peripherally could be a problem. In our patients, they are 25, 40. We have size problems, wherein the femoral artery may be small to access, but that can be easily overcome by suturing a graft and then going on cardiopulmonary bypass through the graft. The seromas and the thrombosis which happen in the West, again, also do not happen with us because most of our patients are valvular surgery and they are on oral anticoagulation post-surgery. So thrombosis and all is automatically taken care of. Having said that, a minimally invasive is a fantastic tool. The day before I came here, we did a 17-year-old AST through a minimally invasive procedure. Beautiful, no scars. Girl is off home on the third day. What I am not, though, very convinced of is perhaps extensive coronary bypass surgery through a left thoracotomy. We have restricted ourselves consciously to LAD, diagonal and OM grafts through a left thoracotomy. Pushed to the corner, we would put these patients on heart-lung machine, which again takes the beauty of minimal invasive coronary bypass away from them, because in a coronary bypass, perhaps off-pump is less invasive than a small thoracotomy. If you talk of endoscopy, and I understand that a part of this program has an endoscopy workshop ongoing, then it is, if you compare these things to a building, 3-floor building, endoscopy perhaps is the second floor, and endoscopy combined with robo is the third floor, and minimally invasive is the first floor. What you cannot do is parachute on the third floor and hope to learn endoscopy and robo straight. Logical step is minimally invasive endoscopy and then perhaps robo-assisted endoscopy. So I think minimally invasive will have a more widespread acceptance and a first logical step to move to endoscopy. Thank you very much.